So this is a 65-year-old male. He had a past history of neuroendocrine carcinoma over rectum. And this is the pleura effusion specimen. Let's check with the focus first. Okay. So in this specimen, you see this quite inflammatory. So in the background, there are quite some inflammatory cells. However, in this cluster, you can appreciate that is like a more three-dimensional groups of cells with very glassy or misty type of chromatin that you cannot see clear like a chromatin granule. It is all smashed. So this is one type of presentation that you will see with the neuroendocrine chromatin, which is somebody would call it like I don't know how to call it in English, but in Chinese it's 消光黑. So you can see that you didn't see any yeah 消光黑, that it's a type of when you are on the street and you see the car which is like with the outfit that it doesn't reflect any light, but it was just absorb the light and give you this type of color. Here you also see two very atypical cells with prominent nucleoli. So this is also seems to be atypical, but given the history, this seems to be the lesional cell that we see, and this is compatible with neuroendocrine chromatin pattern. So because of the diagnosis is neuroendocrine carcinoma, it didn't mention that it's a small cell type or it's a large cell type. So I would just guess it is kind of in between. So here you see it's cell block preparation. You see more like small cell type nuclei, but with quite some cytoplasm, which is much more than what you would see in a small cell carcinoma. So it's kind of like in between, but it doesn't also give you a flank large cell morphology, because usually in the large cell you will see more prominent nucleoli, but you didn't see it here. So this is compatible with the neuroendocrine carcinoma that has metastasized to the pleura cavity. So the second case is kind of more typical that we will see here in East Asia, which is a middle-aged or elder female without any smoking history, but with like dyspnea that at our hospital. That you can see in her pleura effusion, there are definitely a lot of these three-dimensional glandular type of cells, and it is a metastatic carcinoma. So you can appreciate the chromatin pattern is actually much coarse than what we just saw in this neuroendocrine carcinoma. And a majority of these cells we have small but distinct nuclei. And the nuclear membrane contour is also quite irregular. So this is adenocarcinoma, and you see a lot of tumor cells over here. So we will have cell block preparation, which also show a lot of cells over here. For the patient with their initial presentation, we will usually do a TTF1 to confirm that it is coming from the lung primary. We just change a new clone of TTF1, which is supposed to be more specific, because sometimes we will find some colon cell carcinoma or GYN carcinoma positive for our old clone. The new clone is AG7G3. in this preparation, it shows kind of like focal, like a weak to moderate type of staining. So I'm not very sure if it is means that it's positive, or it could be like just cross reaction with other different type of cancer, because it does not show that what we usually see, that very strong diffuse nuclear staining. So in this case, I just call it the TTF1 is focally positive, and let the clinician decide if they want to proceed to perform a EGFR mutation on this specimen. So we might need to just have some more experience with the new clone of antibody. So the next patient is a 57-year-old male present with ascites. So this is the ascites specimen. On low power view, you can see there are quite some singly dispersed cells, but also some cluster that you will see it's more hyperchromatic. There are some single cells looks very bizarre. For example, like this one. It is a large cell, and we seems to be like the chromatin material is like leaking outside of the nuclear. It looks very strange. Also, we see some cluster of cells with three-dimensional architecture and with a very glandular feature. Although the nuclei is kind of small compared to the mesothelial cell over here, but because of the three-dimensional architecture, it is most likely adenocarcinoma. And because of these like a well-differentiated low-grade feature, it is compatible with the pancreatic origin. So you can see there are quite some like adenocarcinoma cells over here. So the architecture pattern in this scenario is very important, because it usually most of the time it won't show the typical nuclear atypia that we just see in the pleural effusion specimen. So this is adenocarcinoma. In some area, you can still appreciate the polymorphism, the variation of the size and the shape of the nuclei. So this is positive for adenocarcinoma, and it's compatible with pancreatobiliary origin. So the next case is also similar. It's also coming from a patient with suspicious history of pancreatic cancer. In this specimen, this is a cytospin specimen. It doesn't, the preparation is not optimal, because you see all the materials are at the edge of the circle. But you can still appreciate that there are some like a cluster of cells with more like a vacuolated cytoplasm, but the variation of the size of the nucleus and the arrangement in the cluster suggests that it is adenocarcinoma. So usually when the pancreatic cancer metastasizes to the body cavity, sometimes the nuclear morphology will be really bland looking, and the architecture pattern, the three-dimensional architecture pattern is really important. And once you identify the atypical cluster, and you get on higher power view, and you see that the nucleus is kind of irregular variation in size and shape, and then you confirm it is adenocarcinoma. So for this case, even though the preparation is not optimal, and the cellularity is low, I think we can still confidently call these adenocarcinoma. So we only have these three clusters, but it looks like a typical glandular cell, and it's positive for metastasizing adenocarcinoma. So the final case is for the pleural effusion is also a lung cancer case. So here you see these like a typical high-grade, very irregular nucleus, and with the vesicular type of chromatin. and you see cherry red nucleoli, and in these three-dimensional cluster of glandular architecture, and this is compatible with lung adenocarcinoma. This is very common in our practice. And cell block preparation also show this typical traction artifact around the periphery of the glandular cells. So this is a typical presentation in the cell block that we see. So let's move on to the aspiration cytology. The first case is a bone aspiration from right pelvic bone. This is the direct smear preparation. The fixation is poor. So I think it is because the clinician didn't put it in the alcohol right away. So it got this severe drying artifact. However, because it is a bone aspiration, these cells are definitely abnormal. So you see a lot of single cells, some cell cluster, and the cell variation in the size and the high NC ratio doesn't look like it's normal. The patient had a non-history of breast cancer. It is compatible with metastatic breast carcinoma, and because the patient also have a biopsy specimen and it is positive for GATA3, so in this corresponding aspiration specimen it is also a breast cancer, so it is positive for carcinoma. So the next specimen is a thyroid FNA. So I have to say, for this type of aspiration, the interpretation is very subjective. So what we have learned is that if we see like scan colloid, in this case, there are still some colloid, but there are not so many. So it's kind of scant. You didn't see that typical thin colloid that we see in the liquid-based preparation. There are only little bit amount of colloid. But on low power field, you can appreciate that the cells are in like a small cluster. It's kind of looks like a starry sky that like a scattered cluster of follicular cell. So in this low power view, you got the impression that it could be a follicular nodule, a follicular neoplasm. So when we go on high power view just to check the nuclear feature, if there is any nuclear feature suggestive of papillary thyroid carcinoma. But you see, these are all very rounded. The chromatin pattern are very delicate. It doesn't show PTC nuclear feature, but it got these like microfollicular arrangement, and it is throughout the entire specimen. And sometimes these microfollicles, because of when we use like a thicker nodule, thicker needle, sometimes the aspiration would just cut the larger chunk of tissue, which can look like these. You see multiple small microfollicle, but it's all clustered together like a large chunk of the tissue. And you also see some endothelial cells, some vasculature over here. So which means that it's a highly vascular lesion because you see the transgressing vessel over here. So you got the impression that it could be a follicular tumor. So whenever I encounter such a case, I always check with the sonography finding, and the sonography finding also show it looks like a follicular nodule, follicular tumor. So in this case, given the higher cellularity, I call it TBS category 4, suspicious for follicular neoplasm. I don't like the new terminology. In the third edition, they cancel the suspicious, but we know a lot of the time when we have surgical excision, some of the nodule was just adenomatous nodule from a multinodular goiter. So I still keep the suspicious terminology. Yeah. So in this case, I call it suspicious for follicular neoplasm. They are still a little bit of colloid, which probably against the diagnostic criteria, but because of the higher severity and the sonographic feature, I still call this suspicious for follicular neoplasm. So the next case is from a bone aspiration of a iliac bone. The patient had a remote history of thyroid cancer, which is a papillary thyroid carcinoma, and clinically it is suspicious for metastatic lesion. So this is a low cellularity specimen, so we see a lot of blood and fluid material in the background, and here we only see one cluster of a typical cells. So the cells does not have flank papillary thyroid carcinoma feature. There is only one cell seems to be quite like a ground glass nuclear morphology with a little bit of irregularity of the nucleus over here. But because it is a metastatic lesion, here we see some microfollicular pattern. Because it is a metastatic lesion, sometimes in a remote metastatic lesion, it doesn't show like a full-blown nuclear feature. So what we can call here is a carcinoma because it's definitely epithelial elements should not be present inside the bone marrow. So we just call it carcinoma. Based on the cytomorphology, we are not very confident that it is coming from the thyroid. Probably can be coming from, because it's an older female, it could be lung cancer, it could be breast cancer as well, so we just call it carcinoma. So the last case is EUS, endoscopic ultrasound guided finding aspiration. The procedure is getting very, very popular here, and we receive more than 200 specimens annually. And I believe this year probably we will have 400 specimens. So we see these specimens very often. So in the endoscopic ultrasound guided aspiration, the aspiration route will passing through the intestine, the intestinal wall, and it can also sample some normal parenchyma of the pancreas. So here you see a ductal like a fragment which has a honeycombing like a arrangement, which means that the distance between each nuclei is equal, is very like a uniform. So this is a benign ductal epithelium over here. And here you start to see some small rosette type of formation. And if you take a closer look, the cytoplasm actually shows a little bit like the gray or a little bit brownish granule. So these are normal pancreatic acinar. So these are acinar cells. So these are all normal elements. So you see normal acinar cell, normal pancreatic duct cell. So here is also acinar cell, and the nucleus is very uniform. But the background is not right. You see some necrotic debris over here. So through the smear direction, and you pick up these highly atypical glandular cluster and with very prominent nucleoli, vesicular chromatin. And pay attention to the size of the nucleus is highly enlarged. So it is a cluster of adenocarcinoma. So here you have some, here is necrotic debris. Here you have some like an acinar cell in compare. So you can see the size of the nucleus is like 4 times even larger than the normal cell population. So the interpretation of pancreatic EUS guided biopsy, you need to know which cell is which cell, because sometimes it all like mix up together. So here are also some necrotic debris, and here are all normal cell admixed with necrotic debris, and here is another cluster of adenocarcinoma that you see with the variation of the size of the nucleus, and you see the distance between each nuclei is highly irregular. Some is very close, some is very distant. So this is called loss of polarity, loss of rearrangement, or sometimes we call this is Juncken honeycombing, that the nucleus are also just feel like a Juncken guy that is swinging around with each other. So this is adenocarcinoma specimen. Okay, that's it today. 明天我早上要去三总那个实验室访查，所以